Thank you. And by the way, the panelists were dropping out. These are only the hardcore medical oncologists that are remaining at the end of 10 o'clock for a panel discussion. Senthil almost looks like in the quilt, almost drowsy, so with a performance status of 3, if not more.
Very soon 4. At the end of the panel, it'll be 5, I'm sure.
Okay. And Senthil, so I would like to ask my first question to you. How much minutes do you want the discussion to be?
End it here, Ullas.
Okay, we will edit.
Sorry, go on. Always, it's always a pleasure. It's always a pleasure to be a part of your panel. Please go ahead, Ullas.
Okay. Is Navneet there? Okay, Navneet is there. Okay, so we have the right people for this end of session discussion. We have Senthil, we have Dr. Abhishek Mahajan, we have Dr. Natasha, Navneet, and Dr. Liza. Fantastic. And so I have been asked to moderate I'll finish in 15 to 20 minutes, partly because my wife is waiting for dinner and I didn't have dinner. So let's see this. So my first reactions when I, in fact, was asked to moderate about the panel discussion on the real implementation of this was like this. So, this is what the real life data of immunotherapy looks like. And this is what the clinical data trial actually looks at. I mean, Senthil, I remember you asking this question to us 6 months back. That is immunotherapy in real life almost effective as what it is in the clinics. My subsequent reactions on that was maybe if the real life data is not very good, you look at Vicky Kaushal. And for both Natasha and Liza, this is the guy that got the most famous Bollywood actress actually. So even if you're Vicky Kaushal like that, you still have hope. So it is for poor oncologists like us. There is still some hope on that. So let's get real about immunotherapy in the clinics. I looked at some of the data which was published from India in the last 2 years. So this was the real world data of immune check inhibitors in solid tumors from Vanita's group, single center retrospectively 3 years data. And they had out of 9,610 patients, only 155 patients could get immunotherapy, 1.5%. Early data till 18, but some data. This was the data from the Jaipur group. And again, in second line, they had 29 patient data, which was there in immunotherapy. So let's get real about this. This was one more data, which I think we all published in the conference, which was organized by Dr. Prabhat Malik. And again, what we saw in 2020, there were 74 patients of non-small cell lung cancer getting immunotherapy in second line. So this is where we are. So let me ask Dr. Senthil, you first. What proportion of your patients get immunotherapy in lung cancer and in what line?
So if somebody can afford and is an appropriate candidate for immuno, they get it in the first line. I don't keep it for the second line. Roughly around 10% would get it. 10% of eligible patients would get it. Okay.
Navneet, how much?
Less than 5%.
Less than 5%. And Navneet is even more drowsier than what you, Senthil, is. So, Dr. Natasha, how much patients in your setting will get? It's cold, man.
Yeah, so technically, I would say that the vast majority of our patients get first line either checkpoint inhibitor alone or with chemotherapy because it is funded through the government. I will say increasingly, I see older, frail patients with squamous lung cancer. And, paclitaxel, carboplatin, and pembrolizumab is a challenge. Nivolumab and ipilimumab plus 2 cycles of chemotherapy is a challenge. So these are patients where, I might give, whether it's single agent chemotherapy or dose-reduced gemcitabine platinum, and then actually switch to second line. So those are the sort of select scenarios where I actually still do use second line immunotherapy, because especially if they're going to benefit, I prefer the single agent.
Okay, so Dr. Natasha, you said if you have a patient who's elderly, will you always use a Keynote 189 or 407? Are you open to use immunotherapy with GemCarb or weekly Pacli carbs or something of that sort?
Yeah, so we tend to follow the trials. I have used Gem Platinum with Pembro safely and other drugs, but we have been tending to use it according to the study protocols.
Okay. Dr. Liza, how much proportion of your patients get IO in first line?
I think in our hospital, it's around 60-70%. We have a Dutch registry where all patients with cancer are entered. And if you look just at stage 4 non-small cell, then approximately half of the patients get any treatment. But usually those that are not treated are either 80 plus or have a very poor performance status or whatever. And those that get treated, if they don't have an oncogenic driver, usually have chemo, immuno, or immunomono, depending on. Usually they don't receive chemo anymore. But we stick to the trial regimens because other regimens are not reimbursed, and then we have a problem.
Okay, let me get either Dr. Vanita or Dr. Kumar on this if they're still there. Vanita, you are there. I asked you, I have a data of 25 patients of immunotherapy in first line PD-L1 more than 50%, and you said 2 less. I didn't look at the data of that. So how much data do you have of yours in first line NSCLC, first line IO Pembro as alone or in combo?
We have a fair number. Again, the proportion of our patients who are able to afford it is small, but I think just because of the sheer volume of numbers, we do have a fair experience with using it.
Ballpark figure.
400-500 maybe.
Of first line immunotherapy?
Yeah.
Oh, that's fantastic. That's actually fantastic. That's something which is very good. So I thought we will.
You're talking over the last few years, no?
I'm talking about the last couple of years. Okay, fair enough, but that's a good one. So let me start with this. There's a lot of talk of NGS actually in the panel, which is moderated by Dr. Vanita. So we have a 55-year-old female who was diagnosed as CA lung with stage 4 adenocarcinoma lung, some pleural effusion and bone mets. The pleural effusion was moderate, drained. She's PS1. Her EGFR AL cross was negative. PDL was 55%. This is what usually happens. She was counseled regarding immunotherapy. They wanted time to decide because the money is huge. We also sent for NGS. The report was awaited. We started the patient on pemetrexed carboplatin. The tolerability was well. In 2 weeks' time, the NGS report came, and that showed a K12C mutation, or let us say it might just show a BRAF mutation. And she's also willing for immunotherapy. So what I'm basically asking you is, what we all know that in EGFR ALK ROS rearranged patients, we will not give immunotherapy. But will you give a single agent chemo immunotherapy alone or in combination in the remaining 6 biomarker altered patients? So let me start with Navneet, and then I'll go to Senthil.
KRAS is fine. Okay.
KRAS is fine. So let me ask you, Navneet, KRAS is fine, BRAF is fine.
I didn't say BRAF.
Okay, I'm asking you. Okay, KRAS is fine, BRAF?
BRAF, I would still tend to offer them a BRAF inhibitor, but KRAS doesn't mandate not withholding immunotherapy for a high PD.
So the KRAS is okay. BRAF is not fine. The other one, the RET and the Entrex and the MET exon 14.
So all of them, the targeted therapy would be preferred. So in them, it should either be just chemo or chemo immuno at best, and targeted therapy whenever feasible. But KRAS is separate.
So KRAS is separate. Other than that, you are okay with giving only in KRAS you're okay to give. For BRAF, MET exon 14, RET and all, you will not add immunotherapy. Is that what I'm getting, Dr. Navneet?
I will not give monoimmunotherapy.
But immunochemo is okay.
If the patient has no access to the appropriate targeted therapy, then you could give the combo.
Fair enough. Senthil.
So if it is KRAS G12C and you want to do monoimmunotherapy, that's fine. But in none of the other driver alterations would we use monoimmunotherapy. That's point number 1. In the other alterations, I would be hesitant, or I would not use a combination of chemo immuno also, because we know that the incremental benefit of adding immunotherapy if you have a driver mutation, barring KRAS G12C, is hardly any or none. So I wouldn't really add in a situation like that. Now, coming to your patient in particular, in this patient with a PD-L1 of 55% being a lady, and the usual Indian lady that we see is a non-smoker, even though the volume of disease that you're seeing is not very significant, I would still be very hesitant to use monoimmunotherapy for obvious reasons, because there is some data based on subgroup analysis to say that this is typically the kind of patient who is less likely to benefit from monoimmunotherapy. A lady, a non-smoker with a PD-L1 just around 55. It's not a contraindication to use, but I would be very hesitant to use immunotherapy as a single agent in this lady, not because of KRAS G12C. It's because of the other clinical characteristics that you're putting up.
Fair enough. So the IO chemo is okay. Only chemo, only mono IO is not. Is that what I'm getting from you also?
So for me,
non-KRAS,
non-KRAS, even chemo IO, I would not use.
Okay, and chemo IO will. So in other words, we are now advocating, since Tony Mock has gone, that we do NGS in all the patients before we put them on immunotherapy.
Absolutely. If we're going to use immunotherapy, then I would certainly want to do NGS to make sure that you're ruling out all the driver mutations before you say it's okay to go ahead and use immunotherapy.
Okay, Dr. Lisa.
Dr. Natasha wants to say something.
Lisa had a very nice smile on the face the moment I said Tony has gone and we are getting NGS. So Dr. Lisa, your comments.
Yeah, sorry, we always try to do NGS before we start therapy, and usually it's feasible. So yeah, we wait, and also we have first-line trials, for example, for RET fusions. So you also don't want to miss these patients. So wait.
So can I ask you? Let's say it's not. Dr. Natasha, just give me a sec. I'll just ask Dr. Lisa once to get my pound of flesh from her first, and then go to you. Okay. So let's say if it's a MET, exon 14 MET or a MET exon 14 MET or a RET, would you be okay in giving chemo immuno?
No, I think for RET, I really don't like it. Yeah, first for RET, we have a clinical trial ongoing first line, so I would try to enroll the patient in the clinical trial. And we can give RET TKI in second line and beyond in a compassionate use program. Okay. And those that had immunotherapy before, we don't have many patients, but they all developed the pneumonitis. So I would really avoid immunotherapy in these patients. And also the data with immunotherapy and RET are not that great. I think for MET exon 14 skipping, I would avoid monoimmunotherapy. In general, the data is not good. I'm not aware of chemoimmunotherapy data in MET exon 14 skipping, but so far I didn't see lots of problems with MET TKI after immuno. But again, we can also give MET TKI upfront, so why not?
Okay, Dr. Natasha.
Oh, thank you. So, I must say that in my clinic, the most important question is does this lady have tobacco exposure? Is she a smoker? Because I think that really remains the most practical indicator of long-term benefit from checkpoint inhibition. So, that's my question. In Canada, we have very good air quality. So I don't know in some of the real world studies, if in India, biomass and pollution also impact. Sorry, I think so I think it's so important. I will say that, in our experience, and we're actually going to publish our MET data shortly, we've actually seen significant activity in KRAS of all types, particularly with smoking activity in MET mutant lung cancer patients, particularly with smoking history, and of course also BRAF V600E. Before we had the targeted therapy, all of my patients that received checkpoint inhibitors are still in remission. So I think those are the three big areas. Agree with Lisa, EGFR, ALK-ROS1, RET, TRAC, and NRG1 fusions. Those are kind of throwaways. I don't really waste. And HER2 to the same extent. That's sort of very low return for your investment. But I think for sure the three associated with smoking, there's a lot more interest. It would be interesting to hear from you guys. Like, does air pollution induce sensitivity to checkpoint inhibitors, or is yours tobacco related as well? There's a lot of good data about that.
So there is no data regarding that, Dr. Natasha, but the point is that we get a lot of women with the non-smoking, at least in the polluted Delhi and the NCR region part over here. But we do have a lot of EGFR mutations also with them. I'm not sure we are analyzing our data of co-mutations in them. So let's see what the data comes up. And my second question to you was, to all of you was, is the reluctance to use immunotherapy because of the lack of efficacy? Or is it because of the, as Tony Mock said, that if you give them pembrolizumab and the half-life is 3 months, you can't use them the other TKIs later. So is it because of the lack of efficacy or is it because of the pneumonitis effect? Any one of you can take. Dr. Natasha?
I'm sure it's the toxicity that gets everyone excited, right? It's just from that very nice paper from Eddie Guerin's team, with patients who died, and the only person who responded with first-line pembro and PD-L1 high EGFR mutant disease was a patient who actually had wild type. So I think it's toxicity that drives us. I think it's important to remember it's not just pneumonitis, right? Hepatitis can be a big challenge in clinic with TKIs and that sort of overlap of checkpoint inhibitors. But I will say to my patients, like, if you can get the targeted therapy, it's best, it's more efficacious. And especially in India, right, where the costs are so high, why would you bankrupt yourself with pembrolizumab when you could, have a TKI or chemotherapy that works, especially in those kind of groups with less benefit.
Okay, so Senthil, forget the good biomarkers. Let's get the bad biomarkers. What about the STK and KEAP mutations? Let's say you do an NGS and you get a KEAP one mutation which comes out of that. Would you want to give, and the PD-L1 is 55%. Immunotherapy, IO chemo, no immunotherapy, nothing. Send them home.
Good question. So that's, as you rightly said, Ullas, it's not a negative predictor of activity. It's a prognostic marker. It's a bad prognostic marker. So irrespective of what therapy you're going to use, this patient is going to do poorly. So in a situation like that, you are likely to have only one go at your patient and you want to put your best foot forward. So in a situation like that, if the patient is fit and is ready to take a combination of immuno and chemo, that's what I would prefer using in this set of
so
patients.
IO chemo, yes, even if it's a KEAP or some mutation. Dr. Navneet.
So this is data which is not yet ready for routine use in clinic. They are indicators of probable immunotherapy resistance, probably poor response. They may be negative prognostic markers, they may be negative predictive, or both. We don't know yet that. But as of now, it doesn't really change decision making.
So IO chemo or single agent IO for you also. Fantastic. I know they are not markers for clinical interest, but I saw the list of my panelists and I had to step up my disco questions. That's just like that. Dr. Liza.
I think not much to add. I think for now, yeah, well, it's not in our panel, so I don't need to think about it in daily clinical practice. But yeah, if I would encounter it, for now, it doesn't change my clinical practice. It's mainly unplanned analysis, retrospective analysis, and it's for sure a negative prognostic marker. So you can discuss that outcome will probably be less, but I'm not using it for clinical decisions.
Dr. Natasha.
Agree. I'm not using it either. I will say that, there's a lot of interest in this KRAS plus SDK, G12C plus SDK11 co-mutations. So we have been testing it in particular because we're putting those patients on KRAS inhibitor trials. But that's just research, nothing standard. KEAP one, it is hard to get. You need a huge panel. And let's face it, it's really just a poor prognostic marker. So I don't use it. I don't need to know.
I think the take-home message regarding STK and KEAP is, to me, is don't include them into your panel. If you don't test for them, you won't find them. And, you will be bereft of difficult answers over there. Let me go to the second one. So, Navneet, I told you I've been looking for questions to match your standards. So, the immunotherapy and autoimmune disorders. So, this is just another patient which comes to us. You are 55-year-old female, again the same, stage 4 NSCLC, lung, pluripotent bone. PD-L1 55%, NGS negative, no actionable mutation. She was counseled regarding immunotherapy, willing, but she has a past history of rheumatoid arthritis. She's on HCQS. She's not on steroids. She says in the winters, I feel my hands do get a bit of stiffness. What do you do? Immunotherapy alone, immunotherapy combo, no immunotherapy.
It's a difficult decision. I would always get rheumatology opinion. In fact, to be very frank, I very recently had a male patient who not just had rheumatoid arthritis, he had hyperthyroidism on treatment, COPD, oxygen dependent, and a high PD-L1.
And you give immunotherapy?
No, I have not given immunotherapy. I got clearance from both rheumatology and endocrinology that you could give immune checkpoint inhibitors. His prednisolone requirement was less than 10 per day, but I started him on nab-paclitaxel, carbo, weekly, this thing, and he's actually now off oxygen, and he's still asking whether he can go on to immunotherapy, but I have been very cautious. Yeah. I really don't want to risk somebody getting a... This is obviously a separate scenario, but I guess you have to discuss the pros and cons.
Okay, the PDL1, Dr. Vanita, was 55%. I've written over here. Okay, Dr. Lisa.
Assuming this is a patient with a smoking history, at least consult with rheumatology. And if the patient is willing to discuss the risks, we have given immunotherapy to patients with rheumatoid arthritis without any problems, or just a little bit steroids sometimes necessary, and that's it, and they're responding and doing well. But we also had very, very invalidating joint problems, that patients barely can function, and that you just cannot get it under control despite extensive immunosuppressive drugs. So patients need to be aware that even with a complete response, because this patient had a complete response, she doesn't have a quality of life. So yeah.
What would you, if I ask you for a second opinion, what would you say? Yes or no?
Yeah, I would advise try it, but be aware of the risks.
Okay. Dr. Natasha.
I agree with Lisa and Navneet. And I think, in the old days, we thought it was a 25% risk of exacerbation of the underlying autoimmune disease and 25% risk of new things. I actually think it's more like 100%. They are going to get something. I recently treated a young guy with rheumatoid that was under control. He has horrifying psoriasis, grade 3. He developed fevers, transaminitis, you name it. His tumor did not respond. So again, it would be interesting in these people with autoimmune disease, is their tumor inflammatory because it's sensitive to checkpoint inhibition, or is it inflammatory just because they have such overactive immune systems? So, it's a group for further study for sure.
So this was an article that I got from Journal of Thoracic Diseases in 2020. They said people who have a non-life-threatening AID, non-neurological AID, and good control, you can actually give. And but the flare-ups occurred, as Dr. Lisa rightly said, in 63% of people. So get your documentation properly, warn the patient properly, and I think then we can go ahead actually. That was another one. So let's just go on to the meat of the matter. Immunotherapy in PDL1 more than 50%. I think we have a lot of options over here. I'm not really going to discuss that. We all know pembrolizumab and single agent and stuff like that. So let me ask. This was the real world data which Solange Peter presented in the first ESMO virtual plenary, and it basically showed that IO chemo combo was not really required in most of the patients with liver diseases or any brain mets, etc., except for smoking. I think Dr. Natasha Lee was the moderator in that session, if I remember rightly. So Dr. Natasha, your take on, so let's say you have a non-smoker lady with 70% PDL1, your take, single agent IO or IO chemo?
Yeah, I would always make sure these patients get some chemotherapy, chemo, immuno for sure. And so, like I said, smoking is a huge factor in my decision-making. And it would be so interesting to know sort of what air quality changes for things in India. And I humbly apologize. This is a fabulous panel discussion. I'm late for a grant meeting and everybody's yelling at me. So I'm so sorry I have to go, but I'm truly honored to be here. And I wish you guys all the best. And that Dr. Hendricks has a wonderful vacation.
Sure. Okay, so we have now 3 hardcore medical oncologists remaining. That's, I think, just a sign for me to sign off. Thanks, Senthil. Just 2 more things from my side. This is what I review, Dr. Lisa. This was Checkmate 227 showing Nivo plus EP in PDL1 more than 50%. And this basically shows that there is a fantastic response. And then when ipilimumab to pembrolizumab came together, the graphs were overlying. So what happened? Any scientific explanation or something? What happened?
I think something like statistical chance that something is positive or negative. Yeah. And to be honest, maybe a subset of patients will benefit from a combination of IO and PD-L1 high, but so far we didn't identify that patient population. And for me, it would be mono immuno unless, so for example, if you have a patient with a no smoking history, then I would really make sure that there is no target. So check the NGS results, maybe do a new biopsy, because usually if you check again, you find something. Okay. And otherwise chemo immuno and a never smoker.
Fair enough. So my last question to Senthil first. Senthil, your choice of immunotherapy in PDL1 less than 1, Keynote 189 or Checkmate or 227? or only chemotherapy?
Okay, less than 1, isn't it? So
Yep.
if it's an adenocarcinoma, it's usually keynote 189.
Okay.
If it's squamous cell carcinoma, though I have not used yet, but the data for 9LA looks very, very attractive.
Okay.
If it's squamous cell carcinoma and it's less than 1 PDL1. So that's how I would split
Okay.
up with you.
Dr. Navneet.
I believe the Pembro trials have been the cleanest trials and the most convincing results, whether that has been mono or combos. And so if it is less than 1%, squamous 407, non-squamous 189, assuming EGFR allograsin is negative.
Okay.
I am not enthused by these combinations of.
Okay. No 2-drug chemo light combination, chemo free. Dr. Lisa.
If a patient is fit, you use the 3-drug. I mean, you use 2 chemo drugs and 1 IO. Okay. Not fit, then just go on to either reduced dosage or some other form of.
So we are 1:1. Let Dr. Lisa decide.
Well, for me, it would, the only thing we can prescribe is chemoimmuno. So the Keynote or the Empower. Then, why give a fourth drug if, you don't have a hint that results will be better? I think the results are the same. Okay. We cannot prescribe at the moment Checkmate 9LA.
Okay.
Maybe that is something indeed for the PD-L1, especially the squamous, because the Keynote 407, the curves, split but then come together again. Still some censored cases, but that could be an option. But so far, I cannot prescribe it.
Okay, last question to Dr. Abhishek Mahajan, who has been waiting very, very silently. Do you actually follow them up with PET CT scans or the CT scans? And how commonly have you seen pseudo progression, hyperprogression in an IO chemo combo? Dr. Abhishek is there? Okay, I kept on saying, okay, he's there.
Follow them up with the routine CECT as protocol of their regular follow-up. We don't do PET CECT. And the chances of having hyperprogression is very rare. We have only seen, I would say, in my experience, under 1% of cases. Pseudo-progression is been more challenging after COVID, where we have seen like multiple patterns because of COVID. But before COVID era, I would say it was under 6%.
Okay. Dr. Navneet, pseudo-progression, hyperprogression, IO chemo combos, first line.
IO chemo combinations, hyperprogression is uncommon. That is a scenario most commonly with monoimmunotherapy. Okay. Pseudoprogression, the problem is if you start doing scans very early for a stable patient. So typically I wait for 4 or 5 cycles or 6 cycles, 3 months on treatment, and then do a scan if they are clinically stable.
Okay. So don't do scans, don't do NGS, don't do keep. That's the mantra today.
Okay. Don't go to hospital. Don't go to hospital. That's even better.
There are other parameters which we tend to forget, like apart from imaging, which might guide you to pseudoprogression, the hormonal profile, and also the changes elsewhere. Like if you are looking at the thyroid profiles and other things, which are more common than the pseudoprogression happening in the lung itself. So, are we really looking at the clinical profile of the patient to pick early pseudoprogression? That's my question.
Okay, so Senthil, you want to take that? I think we do regularly. We do. I mean, all these hormonal profiles. Senthil, you take on this.
How do you manage patients progressing on immunotherapy? Is that what you're asking about? That question or the pseudoprogression, hyperprogression?
We do depend on pseudoprogression in lung, but are we looking at pseudoprogression, which are the other clinical markers? Like the hormonal profile is, I think, an early marker of patient undergoing pseudoprogression.
I don't know. I'm sorry. I'm not aware of anything.
We've done a study on endocrinological abnormalities on patients on immune checkpoint inhibitors, and it has been reassuring. It's not very common. In fact, even outside of this study, I routinely get a thyroid profile every 2 or 3 cycles and a urine analysis every 2 or 3 cycles, and it is not something which has really caused treatment interruption, barring a couple of patients in whom it really shot up and I had to stop immunotherapy. So just the way you monitor routine blood work, I think thyroid profile has to be sort of done the same way, although at a lesser frequency. And short of CT scans, you can always get chest radiographs, which are simple to get any idea if you have a suspicion of pneumonitis or anything like that, even though they may not be very sensitive.
Okay, so I think that was my last question. And this is to conclude. I think we are moving towards hope. Hope in the sense that immunotherapy has gone from second line to first line to adjuvant to new adjuvant now. And definitely there are exciting times ahead. So for the people who are really awake right now, thank you for bearing with us. And a special thanks to Dr. Liza for staying, and 100 Dr. organizers. Thank you.